So let's find something that's better. Or something else which I'm going to pursue and try to make the case for you all today, which is the idea of exploit, then repeal. And when I say exploit, there are some good things inside the Affordable Care Act that I want to highlight, and I'm going to say if we exploit those facets of it, of the Affordable Care Act, and then repeal it, we can avoid the stress and anxiety associated with the initial deployment of the Affordable Care Act, where people didn't know if they were going to have their care. People were discontinued in the middle of certain care practices. They were having their doctors reshuffled around. People in the middle of cancer treatments were now being denied their coverage. We don't want to do that when we start talking about repealing and going to a better system. So let's set it up so that we make sure that we have that continuity of care. I'm not so concerned about all the bureaucracy behind and their stability. I am concerned about the stability of that doctor-patient relationship. So, why exploit then repeal? Well, first of all, it's unlikely that President Obama is going to support any legislation that's going to repeal his namesake legislation. Number two, let's take some time to jumpstart a free market healthcare system within the confines of the Affordable Care Act. Number three, let's avoid that uncertainty we were talking about before. And then, from my perspective, I think when we actually go in and start implementing some of the reforms that we're talking about in this presentation, I think you're going to be able to make a case that kind of expose what the true intentions of this spaghetti diagram actually were, as opposed to what its stated intentions were. And last but not least, I actually do want to achieve these objectives. I do want to lower the cost of healthcare. I do want to improve the quality and coverage and protect consumer choice. I think those are laudable goals. So, we're going to zero in on a couple key sections. You don't have to worry about all sections of this, and there's over 10,000 of them. By the way, I read all of HR 3200, which was 1,017 pages back before I decided to run for office. HR 3590 is only around 970 pages with all kinds of nested references to other laws. It's not an easy read. I know half of your textbooks are probably about that length as it is. But I just want to zero in on a couple of the key sections. First of all, the concept of a qualified health plan and minimum essential benefits. This is the idea of a mandated minimum health care coverage that everybody's required to go off and have now in the United States. So this is where you'll get a listing of all the different mandates from the federal government to go along with all the mandates that we have out of the state government already. I think Michigan has 25 unique mandates already on their insurance code. One thing I want to highlight too, and this is kind of a key theme whenever you're talking about healthcare, insurance does not equal care. You may have a card, you may have something that says, I may have my My Child card, but that does not mean that I'm actually going to be able to see a physician or that I'm going to get good quality care. And I personally am passionate about making sure people get good care. So all those minimum essential benefits apply to insurance. Now, Section 1311 deals with state-based exchanges. Section 1321 deals with the federal health exchange. They are different sections, and that plays into why it's important that Michigan pursue a federal exchange as opposed to a state-based exchange, and we'll talk to you about it later. But it deals with the Supreme Court case that's going to be heard up in March of next year.